Hi everyone, you are watching Oral Encyclopedia. Our today topic is Lichen planus. Lichen planus is derived from Greek language, where lichen means tree moss and planus means flat. Clinically, it is a chronic immunological mucocutaneous disorder that appears as a white or grey line with pruritic papular rashes on the skin. This white striae and punctuations like appearance is also known as Wickham striae. Now let's discuss the etiology of lichen planus. It is idiopathic, that means exact etiology is unknown. Moreover, it is a T cell mediated disorder where the production of cytokines lead to apoptosis. Additionally, certain factors such as genetic predisposition, environmental influence, lifestyle factors can trigger the immune system. Psychological factors like anxiety and depression, as well as dental materials and infectious agents such as gram-negative bacteria and candida, have also been associated with lichen planus in humans. Now coming to the clinical features of lichen planus. It is commonly seen in adult with a higher prevalence in females. It appears as a white papules that form a network of line with the presence of grey or white dots. Moreover, the skin involvement present as a purple pruritic papules mainly seen on the flexor aspect of the wrist, ankle and extensor aspect of the lower leg. It can also affect the skin of lower central back area and natal clefts. In the scalp, it leads to scarring and scaling, which may cause alopecia, that means hair loss. Clinically, 6 types of lichen planus are present, such as reticular, papular, plaque, erosive, atrophic and bullous. Let's start with reticular lichen planus. The most common type, which is asymptomatic. Clinically, it appears as white striae with a web-like appearance. Thus, white striae are surrounded by an erythematous border. The most common sites are buccal mucosa, tongue and gingiva. Next is plaque lichen planus, which resembles leukoplakia and clinically appears as a homogeneous white lesion. Additionally, bullous lichen planus present with very small blisters that rupture to form ulcer. The size of the ulcer varies from a few millimeter to several centimeter. The next type is erosive lichen planus. It is the second most common type of lichen planus and has a greater potential for malignant transformation. It primarily affects the lingual and buccal mucosa. Furthermore, atrophic lichen planus, it clinically appears as a diffuse red patches and surrounded by white striae, sometimes representing desquamative gingivitis. Now let's discuss the management of lichen planus. First and foremost, we need to identify whether lichen planus is symptomatic or asymptomatic before deciding on treatment. If the condition is asymptomatic, advise regular follow-up every 3 months. The treatment modalities changes in new cases and recalcitrant cases depending upon whether the condition is symptomatic. Initially, prescribe antifungal therapy with clotrimazole to be used 3 times a day for 1 week. If there is no relief in symptoms after using clotrimazole, topical steroids can be used in new cases. Triamcinolone acetonide and fluocinolone acetonide are the preferred options and should be used for 1 to 2 months. However, if there is still no relief in topical steroids, combination therapy may be advised, including both systemic drugs and topical steroids. Likewise, in recalcitrant cases where there is no relief in symptoms after the use of antifungal agents, different treatment methods should be considered. Initially, intralesional injections can be used. Moreover, immune modulation drugs, immunosuppressive drugs, PUA therapy may also be considered. I uploaded a new video on lichen planus. Please watch, subscribe and share it with others. Thank you for your support.